I was reminded as you're all having biryani that one aspect of cuisine that we are not so familiar with is that the chili that we love actually stimulates the pain receptors in the oral cavity. It is not a flavor, but a pain inducer. And in combination with spices, the pain actually is pleasurable. So that's something to think about after lunch. So I'm very glad to introduce now for the next session Dr. K.S. Jacob, who is a former professor and head of psychiatry here at Vellore and currently working at the Chittoor campus, and very well qualified to give us a view on the holistic approach to pain. Dr. K.S. has a wide spectrum if we look at his experience from local community to state, national, and international experiences in his psychiatric journey, and also from academic to practice to community-based work. So he is best suited to give us the holistic approach to pain. Thank you.
Thanks, Paul, for those kind words. And I'd like to thank Chaplaincy for giving me this opportunity to speak. Before I start, I must mention some conflicts of interest. My background being psychiatry and having been trained in psychology and anthropology and some public health, I approach this problem from these fields and from a scientific perspective. Now, this talk is not about pain, acute pain, or pain related to cancer, but this is about how to manage chronic pain. Now, the first point I'd like to make is that pain is really not well understood. Pain is not one kind of problem, there are many kinds of pains. And we don't fully understand the mechanism by which we feel and appreciate pain. Now, as a specialist, after having trained in psychiatry for many, many years, I decided to work in Chad Hospital. And I used to go there once a week and sit in the outpatient. And I realized that actually all my training, my specialist training, was not really adequate for the kind of pain and problems I used to see in primary care and secondary care. So it took me a long time to understand that it's not my discipline I need to communicate to my patients, but fully understand their kind of problems and where they come from. So I let go of my specialist approaches for a more disciplinary, for a more general approach. I let go of my specialist training and got out of my disciplinary perspective. And I asked the question, whose mental health or whose health are we talking about? Are we talking about our own health? Do we, at the end of this encounter, want to feel good about ourselves? Or are we talking about trying to relieve this other person's pain and problems? So this talk is about a broad approach using different disciplines to come up with a general and a practical package on how to manage pain. So this talk would have, it's divided, I will discuss some clinical issues, some physiology, some philosophy, some assessment, principles of management, and a practical approach to pain. Now, pain is defined, there are many definitions, but the main components are that pain is an unpleasant sensory and emotional experience. So there are two parts to it. There's some sensation and there's an unpleasantness. We all know that pain and suffering are part of life, and you can't have life without pain and some form of suffering. But this pain is a multi-dimensional phenomena, and it cannot be reduced to a single dimension. And I shall try to discuss this in this talk on a holistic approach to pain. So we have a wide range of painful disorders from mild discomfort to agony. Some of our people have complicated histories. Many of them have complex social problems. Now, there are many types of pain, and I feel that I sat through only today's discussion, but there is a tendency to view pain as a single entity with increasing intensity. But actually, there are many different kinds of mechanisms of pain which we fully don't understand. Broadly, the definition is acute is less than 3 months, chronic pain is more than 3 months, and these are different kinds of phenomena. I'm sure this has been discussed, nociceptive pain due to injury, which is an early warning device. We have inflammatory pain, which is actually protection, where it's hypersensitivity and the body is asking for protection from further injury. You have neuropathic pain, which is malfunction of the central nervous system or the nervous system. Then you have psychosomatic pain, where there's some change, they say, in the signals being amplified. Now, as I said, pain is a really complex problem, and we don't really understand pain. There are diverse mechanisms, varied presentations, assorted contexts, variable responses to pain, and many people have different causes and outcomes, some with good outcomes, some with terrible outcomes. So one of the things we have to understand is there is no single or simple solution. Sometimes when I hear people talking about pain, they talk as if there is only one solution. If you do this, everything is all right. I don't think that's the case, and we don't have any simple answers to these complex issues about human suffering. Now, we know that pain has huge impact. It impairs function. It causes a lot of distress. This huge distress in psychiatric terms, which psychiatry has medicalized, is called depression, anxiety. People can have intense thoughts of death and suicide. But this is essentially distress. People with lots of pain can use substances, alcohol, cocaine, cannabis. These are all substances of choice when people not just go through physical pain, but also mental agony. Many patients also become dependent on these substances. As a psychiatrist, we tend to see people who are unable to get off these medicines. Yes, the medication was given for some acute injury, and now they have become dependent on it. We know that intense pain causes a poor quality of life. Intense pain can cause huge interpersonal problems. It can not only destroy individuals, but families and communities as well. Now, let's look at some predictors of outcome. What kind of conditions will worsen the pain, and what kind of conditions will improve the pain? So if you have a condition like cancer or some other chronic medical problem, that, depending on the trajectory of that illness, your outcome will be good or bad. But if that outcome is poor, then pain may persist. If you have associated sleep disturbance, the pain will get worse. If you have what is called persistent pain behaviors, like for example, you've injured some part of the body, then you don't use the limb, and if you don't continue to use the limb as a protection against pain, soon you may find that you may have difficulty in using the limb, and the pain can become chronic. So there are certain pain behaviors which will make things worse. Although initially they were useful, they become sort of not really useful later. If you have distress, anxiety, depression, the outcomes may be worse. Now, what are the good outcomes? The good outcome factors are good relationships, good financial security, satisfying work, and an environment which allows for personal growth, where you can develop resilience against stress and adversity, an environment which allows cultural and spiritual perspectives, where you can develop life and occupational skills, where you have support during crisis, and you have health and social security, healthcare and social security. Now, many doctors know as soon as they see you, very quickly they realize that some patients are really difficult to manage. But there is a problem with pain assessment. Many studies have shown that there is a huge variability in assessment. So if you're a woman, the doctor won't listen to your problems, they'll dismiss it. If you're an older person, the chances that they take your pain seriously are much less. If you're poor and from the lower socioeconomic status, then you may not get the doctor's full attention. Caste is a big issue in India. If you're from a lower caste, then the doctor will dismiss your complaints as not serious. Race in the US is a big issue. People from African Americans, there is so much bias against them that even when they are in genuine pain, the doctors don't take them seriously. So whenever such patients who have chronic pain come up, doctors tend to downplay their symptoms, they ignore their distress, they dismiss their concern. It's mainly because the doctors don't know what to do about these patients. They don't know how to handle these patients because they are never taught during their training how to manage these patients. So they tend to refer the patients or turf them on to other departments, saying you go here or you go there. Now what happens is when people are not listened to or dismissed, they become really dissatisfied, and then they tend to shop for doctors. They go from pillar to post, hospital to hospital, looking for some kind of solutions. Now, just a word on physiology of pain. It's not just a sensation, it's an experience. And this is a subjective experience. And as outsiders to this pain, it is very difficult for us to evaluate this pain. You know, you can have a Likert scale 1 to 10 point, or you can have smiley faces turning red. But we truly don't understand this pain and discomfort that others feel. So there is an intensity or a sensory dimension, and there is an unpleasantness or an affective dimension. Some people feel that these dimensions are completely separate and that they can be differentially treated and modified, which is kind of questionable. From an evolutionary perspective, pain is a useful signal. However, persistence of pain, once the message has been delivered, can become problematic and distressing. So we clearly know that there's an evolutionary advantage with acute pain, that those who have acute pain can rectify the causes, and if they do that, there is an evolutionary advantage. They will live and reproduce and give birth to children, and then as an evolutionary mechanism, appreciating acute pain and responding to it is a great idea. But what is the usefulness of chronic pain? And that becomes problematic to explain from an evolutionary perspective. But we know that human societies, although if you have chronic pain, it's a definite disadvantage, we know that human societies look after their sick people, so this disadvantage is mitigated. Now, coming to some sociological perspectives. What has happened to human societies is that there's a medicalization of pain, suffering, and even death. There's a shift from, let's take a significant event like death, from a social event and an experience to a medical problem. So we have actually medicalized death, where instead of the person quietly dying in 2 days, they will then be put into ICU, intubated. If you have more money, they'll put an ECMO machine as well. So this social events of pain and suffering, social events for which we have to look for meaning, social events within the context of relationship, this social events of pain within communities have been fully medicalized. So the focus becomes on the individual, and you interpret pain as a disease, and even death as a disease. And many doctors feel that you're defeated if the patient dies, even in their old age. We have, as a society, normalized structural violence. Capitalism has normalized poverty, and you blame poor people for being lazy. Patriarchy, which is supported by all religions, or most religions, has produced gender injustice. Caste discrimination in the Indian subcontinent, which is across all religions in this region, is a huge problem. And now to add to it, the religious discrimination and intolerance we see now adds a new dimension to this problem. The political economy of health, that is market forces and capitalism, have also medicalized life. There's a huge cost of medical care, and many people are known to go into poverty because of catastrophic out-of-pocket health expenditure. So now, from a sociological perspective and a pain perspective, we actually need a balance between pain relief. Nobody should suffer from pain. But we also have to look at its meaning and pain within family relationships and community connections. We not only have to look at pain as an individual problem, but a challenge to communities. Now, just a brief slide on the physiology of pain. I know that Christianity values suffering and adversity, and I think many people in this symposium have alluded to that. That pain can give meaning to life. But yet, all of us do our best to avoid suffering in our own lives. So the question others ask is, suffering does not always promote growth. Although we may keep saying that I did benefit from my suffering, I can assure you most of us haven't really seen horrific suffering. Most of us who are talking here are people who have not really felt the kind of suffering some of our patients feel. Severe suffering can destroy lives, can break up families. So people who are non-Christian philosophers would argue that suffering has no real value. That while small doses of suffering can lead to resilience, that the value of suffering is an illusion. But whatever our philosophical take on pain, we all need to prepare for illness, for social adversity, for old age and bereavement. Now, the task before us when we see pain, people in pain and suffering, you have to ask how much of it is a biological contribution due to disease or underlying medical condition, how much of it is an early reaction, the initial shock that something is going wrong and I have severe pain, the late disappointment that after months this pain hasn't gone away, where is God, and questions like that. Then you have to ask the question, is there some gain? Is there some sick role which this person has now adopted, which although initially was useful, it allowed for some period of restitution, has now become part of their lifestyle. So which means that the approach to this problem is different. We have to ask the question, has the person become addicted to the medication? And that requires another kind of approach. Just a note on opioid addiction. So all pain relief is for analgesia, but the stronger opioid medication produces a euphoria, which is a high which many people would like. It also produces a withdrawal, which results in a lot of distress, and so people then seek out opioids to prevent withdrawal, and both these results in addiction. In the US, there's an opioid crisis now with deaths due to opioid overdose. And if you've been reading the papers, many of the pharmaceutical industries they've been implicated on pushing these opioids, paying doctors to push them, which has resulted in a lot of deaths and overdoses. There's a huge differential when the opioid problem was among black communities and now that it is affecting white lives. But in this opioid crisis, genuine pain has also been demonized. So coming to assessment, it's always not easy to talk about pain. It is even more difficult to listen to stories about pain, and it actually demands active listening. The challenge is to come up with some kind of a observer assessment for a phenomena which is essentially subjective distress. We need to evaluate the physical components. We need to evaluate the emotional aspects of pain. We need to look at pain behaviors which results in reduced activity, avoidance, and changed lifestyle. So sometimes the short-term initial gains can lead to a long-term disability. We need to do an analysis of behaviors. What were you doing when this pain became worse? And what was the consequence when the pain became worse? So we need to look at acute and chronic stress, physical problems, psychological issues, precipitating and perpetuating factors, mitigating and exacerbating circumstances. We need to look at attitudes, personality, and lifestyle which contribute to pain. Now, what are the principles of management? Pain management is part of every doctor-patient relationship, is part of every counselor-patient or client relationship. It demands active listening. Pain needs to be approached from a multidisciplinary perspective, and we shouldn't stick in our silos and say that's outside my boundary, outside my training. We need to all have a multidisciplinary approach to these problems. We need to individualize people's treatment plans. We need to involve them in decision making. Now, what are the components of good pain programs? You need exercise programs and physical activity, occupational and physiotherapy. You need stress reduction strategies like religion, prayer, yoga, and meditation. You need psychological therapy. Acupuncture is useful in chronic pain, and you need medication management. But the focus shouldn't be on the pain, focus should be on functioning. Now, the challenge for us is to translate this theory, which I have quickly run through into practice, to provide a multidisciplinary approach to support people with chronic pain, to empower them, to change their perspectives, and to reduce suffering and improve their function. Now, this is actually a tall ask, and many specialists who are talking from their own disciplinary background don't appreciate the challenge and don't see the need to move out of their comfort zone and come and talk about areas they may not be very comfortable with. So, having worked in Chad for over 10 years and with a lot of trials, we came up with this 10 steps program to manage pain and other kinds of suffering. And I shall take you through these steps. So the aim of this talk is not to give you some theoretical understanding, but to actually tell you how each one of you can approach people in pain and manage them. And I will briefly mention each step. So we need to recognize the presentation. We need to acknowledge distress. We need to elicit patient and family perspectives. We need to review their physical status, lab tests, and treatment. We need to educate, reassure, and explain things to them. We can prescribe medication. We need to discuss stress as cause and consequence. We need to discuss coping. We need to negotiate a plan of compliance to treatment and responsibility. And we need to give appointments for continued support. Now, the first issue. Even if we think that this patient has been seen by n number of doctors, has been investigated extensively, as this has been going on for a long time, to show that we are dead serious about assessing their pain, we have to start from the beginning. How did it start? How long have you had this? How severe is it? What is the quality of the pain? Can you function? Are you incapacitated? When does the pain go up? When does it come down? How has it changed your responsibility? How has it changed your lifestyle? What kind of medication do you use? What has been the response to medication? Do you use non-medical strategies as well? The aim of this exercise of seeing this patient is to, one is for doctors, is to exclude causes. But even if you're not a doctor, I will tell you how you can look at these issues. If medical causes have been excluded, then the question is, or the patient has an underlying medical condition, you have to ask this question, is the pain and its impact out of proportion to the underlying medical problem? That is the question which this encounter will need to address. Now, after you start asking details about the patient, the first thing you should do after listening to their story is to acknowledge that it's distressing. Whatever their presentation, I've got aches and pains, I'm not sleeping, whatever is happening to me, because you know that at the end of this session, you're going to tell them either that there is no serious medical problem or that some specialist feels that that's all they can do, now you need to get on with it. So to show that you understand their problem, you have to acknowledge their distress. It shows understanding, it shows empathy, it will help build your rapport, and it is the start of a therapeutic alliance to reduce pain. Now, the third step in this is to find out patient perspective. Very often, doctors don't bother to ask what do the patients think. But in persistent pain and persistent problems which don't have an underlying medical cause, you need to ask this question, what do you think is the cause of your pain? And if you know the cause of your pain, then there can be a focused review, you can give very specific reassurance, and you can give them an explanation when the pain recurs. I can give you some examples. A young person comes and says, I have chest pain. You know that at this age you don't develop myocardial infarction or angina. And you must ask them, what are you worried about? And it may be that some relative died of uncle died of a heart attack. And he's worried that he may have a heart attack and he's having recurrent pain which the doctors are dismissing. So if you find out what is their worry, then you can address their specific concern. Now, I have been studying this patient beliefs for a long time, and I have in a wide variety of patients, and you find that you have lots of medical kinds of belief. This is a disease, this is degeneration, this is deficiency, and these medical beliefs coexist with a lot of supernatural beliefs. This is karma, this is black magic, this is sin, this is punishment by God, this is because some planet went into some constellation. Now the question is, we are trained to be logical and rational, and if you have one belief, you should have one action. But actually in the community you find that people hold multiple beliefs simultaneously which contradict each other, and they seek simultaneously, either in sequence or in concurrently, different kinds of medication, either from a hospital or from the temple or church or from the traditional healer or black magic guy. So you need to find out what are the kinds of beliefs you hold, what are the kinds of treatments you have sought. Now coming to this point of assessment of the pain. Now, if you're a doctor, you're supposed to do many things. But if you're not a doctor, psychiatrists are not supposed to be true doctors. So I find myself in this situation where even though I may not do the physical examination, I will elicit the history of illness. I will tell them, tell me what tests have you had in the past, what treatments did you go through, study their patient records, look at their reports, understand what was found and what was not found, examine what response happened to previous treatments, analyze the impact of their illness, identify fluctuations and exacerbations and their explanation. And then, even without a physical examination and more tests, you can make a reasonable assessment, because many of these chronic pain patients have gone from pillar to post looking for solutions. This will actually increase the patient satisfaction because you have gone through their history. Now, the fifth point is education. Now, you will have to educate them that you can have pain in the absence of medical illness. You can have pain which is not fully explained by their medical illness. But the important thing about this education is you should not dismiss their beliefs. You may not believe in black magic. That doesn't matter. Your beliefs don't matter. It is what the patient believes. So you have to elicit their beliefs. You have to discuss their beliefs. Now, most pain patients, even if they say God's will or black magic, they are still looking for a medical model. Give me some tablets. And actually, medicine actually failed many of these people. I'm not talking about cancer pain and palliative care. I'm talking of chronic pain. And we need to shift them gently from this pure medical model of illness that the doctor will sort your pain out to a psychological model of illness. We need to shift them from tablets to non-medical solutions. We need to shift them from pain to coping, from cure, which promises zero pain, to a healing to get on with their lives, from a pain-free status to improve functions. We must encourage multiple explanatory models or coping strategies, whatever will benefit the patient to reduce their suffering, and whatever they think will help them reduce their pain. So very often we are dealing with, sure, you can go to the church. Sure, in fact, if you're religiously inclined, you are going to the church. Many people in pain stop going to church. And I always tell them, please go back to the church. Please go back and pray every day. So you have to look at what they're inclined, what they believe in, and then tell them to do. So going to the temple, puja every day is very, very useful for people in pain and distress. So we must encourage diverse, multiple, simultaneous help seeking from diverse sources. Now, we need to consider medication definitely, but we have to ask the question, do they require multivitamins and placebo? You should remember that placebo releases endorphins in the brain, so it's not just a sugar-coated pill. It has a huge impact on pain. Or do they really need pain medication? Can we go up the pain ladder? Can we treat the underlying medical condition? Do they need paracetamol or NSAIDs or pain modulators or mild opioids? If they are distressed, depressed, anxious, and with persistent pain and sleep disturbance, maybe an antidepressant will help. You need to discuss stress, both as a cause of the pain, as a cause for exacerbation, as a cause for it being perpetuated, and as a consequence. We need to mention the link between stress and pain. You can give some examples. I've seen many vague aches and pains in young men, and very often they would have seen many doctors. Usually aches and pains in young men is usually some kind of sexual misconception or sexual problem which they can't talk about. So somatization becomes a proxy, hoping that the doctor or person will ask them about this. Very often in young women, it is a fear of pregnancy. And of course, the husbands will say, no, sir, it's not a problem. They won't be using contraception. And a woman's life can be turned upside down if she gets pregnant. So a simple solution to many of these kinds of pain may be just prescribing contraception. So you need to ask for examples of stress and give some explanations. For example, if you're stressed and tired from work, if you're not sleeping at night, surely the next day you're not functional because you've been tossing and turning and you're tired. So you need to explore the stress and give some kind of explanations as to the link between stress and poor coping with pain. Now you need to come up with some general stress reduction strategies. Physical exercise, not just for pain, is good for mental health. At least a half an hour, 45-minute walk every day. Good nutrition, good sleep hygiene, hobbies and leisure. You have various general stress management techniques. Religious activities really help a lot of people, particularly those who are inclined. You don't have to tell what you believe in. Whatever the person believes in, you must encourage them to continue these activities, increase them. Time management is crucial. Many people have too many tasks they're juggling with. Helping them with time budgeting would help. There is some relaxation training. Now, what happens when you're stressed or anxious, your muscles get tensed up and you get more anxious. So if you can train your muscles to be relaxed, the anxiety and distress comes down. The same thing is true of rapid breathing. If you breathe rapidly when you're anxious, the anxiety increases. And either you train them with breathing exercises to reduce their rate, or Jacobson's progressive muscle relaxation. But I find that yoga is a great idea because the theory of yoga is no longer true, whatever they believed in. But the practice of yoga, and only 2 asanas, there are many asanas where you will rupture your ligaments. I have done this course myself. So I wouldn't recommend any of those gymnastics and contortions. Only pranayama and shavasana. And the advantage of these 2 yogas is just tell them. In fact, in Chittoor, because I can't, my Telugu is not that good, I will put on a Shavasana in Telugu YouTube and make them listen with me and tell them, you please go and practice like this. And that actually helps many of these people. Those who are inclined to meditation, that helps. Now we need to do this activity pacing. That is, we have to pace their activities and make it graded so that there is no fear of pain and there is no avoidance of activity. We need to discuss lifestyle changes. And these kind of general stress reduction strategies should not be just for Sunday to go to church, but it should be part of an everyday routine. Now we need to discuss coping strategies. For chronic pain, there has to be some kind of acceptance. There also has to be definite change in attitude, philosophy, and lifestyle, maybe reduced expectation. There has to be an increase in understanding of their personality, which is contributing to the pain experience. We need to manage pain behaviors. That is, what are they avoiding, and how can we come up with a graded plan to increase their functioning? They need to seek help from diverse sources to match their beliefs. And if anger is an issue or assertiveness is a problem, you can discuss other strategies as well. Now we need to negotiate with them, time for them to think about solutions, come up with a pain diary to write antecedents, behaviors, and consequences. We need to discuss their expectations of cures. They would have already for years been going around from pillar to post. Maybe they need to change the way they look at the issues. They need to focus on functioning rather than on pain. They need to take responsibility for stress reduction. They need to take responsibility for improvement. They have to become part of the shared decision making, and we need to individualize care. And last but not the least, you must promise support, continued support, give them specific appointments where you will review their progress. You give them homework, review their homework and pain diaries, and give them time to think about additional approaches, and you need to shift their focus from symptoms and pain to coping and functioning. Now, I've run through this very quickly. When I first started this 10 steps, it used to take me 45 minutes with each patient. But with every time I did this, actually, you can become quite good at it. And you can reduce it to 10 to 15 minutes per patient. I used to work in Chad. Although I was professor of psychiatry, I used to work as a general physician looking at their physical complaints, doing their physical exams. And I find that you can use these 10 steps in 10 to 15 minutes. But I believe that each of these steps is very crucial. We have to recognize the presentation. We have to acknowledge distress. We have to elicit their perspectives. We have to review their physical status and treatments. We have to educate, reassure, and explain. You have to tell them, yes, you have this pain, but you're not going to die because of this. You're not going to have a stroke because of it. Yes, they may need some medication which they can continue, but we need to discuss stress and coping. We need to negotiate their responsibility and in stress reduction and in changing their lifestyle. We need to give them appointments for review so that we're not abandoning them, but that we will continue support. Now, since my talk is very practical, and all of you are going to be, I presume, in some form counselors or therapists, or definitely will plan to counsel, we have to ask ourselves these questions. Are you uncomfortable listening to pain and suffering? Are you willing to spend time? Are you willing to provide long-term support? Are you compelled to suggest quick solutions? Do you want a quick resolution of the pain? Will you push your own points of view rather than listen to the patient's context? Will you empower the patients to look for their own solutions? Will you look for opportunities to expand your repertoire of therapies which you know what to do, how to do? Will you take on difficult patients and treat them? Very often I find people don't want to spend time. Supposing the patient says, I'm worried about my pain, and you tell them, take this tablet. The right response is, tell me about your pain and tell me about your worries. So many doctors just say, take this tablet and dismiss people. Now, what are the qualities of a good therapist? You know, in psychology and psychiatry, there are a zillion schools of psychotherapy, from psychoanalysis to cognitive behavior therapy to gestalt therapy, each of them claiming to be superior to the next. But actually, there's been an analysis of qualities of good therapists and therapies. And these are some of the issues which you need to do. And when I was training in psychiatry, I would tell myself in this session, I will try these two approaches, so that now, very often, I find that many of them have become second nature. So the first is relationship factors. Do you have unconditional positive regard for this person? Or will you say this person is a pain, I've heard them before, they will complain about the same things? Will you be a role model of calmness and composure and patience and teach them how to go through a graded program? Will you use your resources as a therapist and your strategies and solutions to help meet their needs? Then there are these expectancies effects. Now, what are your expectancies? Do you think this patient will improve? Are you optimistic that they will improve? Or do you feel this is hopeless, I might as well prescribe some medicine and send them on their way? Similarly, treatment credibility. If they feel that this treatment, for example, in India, tablets and injections have huge credibility. So if you tell somebody it's all in your head, no tablets, just come back to me, that doesn't work. So definitely at the start of therapy, some kind of multivitamin tablets at least should be given. But as your relationship progresses, they themselves will say, I stopped this tablet 2 weeks ago and I'm all doing all right. Similarly, there's some culturally defined approaches and also expectancy and efficacy about the self, which the patient will have or won't have. Now, what we need to do is, we need to dismantle dysfunctional patterns by mobilizing disaffection for the current state, saying that, you're suffering, it's not a good situation for you, and you have to loosen and modify the situation which is holding them in this particular place. We need to provide new perspectives and concepts, provide an orderly account of issues, reframe, redefine issues, conceptualize change differently, confront problems differently. We should provide hope, provide a provision for success. The suggestions should involve some effort from the patient's part, and there can be some surprising therapeutic impacts as well. So good therapists have these kind of repertoires, and all of us should try and master them. So the challenge is changes in philosophy of life, and not just for our patients, but for ourselves as well. Do we review past bruises and difficult situations in life and let go? Do we have a pre-rehearsal of possible future suffering? Are we hedging our bets about the future and wonder things may not go according to plan? Do we accept our vulnerability as human beings? Will I be able to diagnose and manage some patients? And the answer is yes. You can manage patients in your practice. It gives you, as a frontline worker, 30% of your problems are like this only. And if you master how to deal with these, you can derive a lot of satisfaction and help a lot of people in distress. Will I be able to solve patients' psychosocial problem? The answer is no. It's not our responsibility to solve their problem, but we need to empower them to resolve the problems themselves. We need to support them, but they need to come up with solutions to their own adversity, and you shouldn't come up with ideas as what you would do, because your situation is completely different from theirs. How can I gain skill and confidence? It's practice, and more confidence. It is not just a matter of knowing some knowledge and jargon. It's a question of applying it in practice. It's a skill which you need to learn. It is confidence you need to develop. And with this sense of mastery, you will recognize this problem more often. You will treat people like this. There's a lot of patient and clinician satisfaction. When should I refer patients to specialists? If there's suicidal risk, if there's complete non-response to treatment, if they have very incapacitating conditions, if there are severe interpersonal problems, if there's chronic substance use, and medication addiction and dependence. I know I have rushed through this. My slides can be easily made available. Pain is a complex and multidimensional problem. There are no single or simple answers. We need to break our disciplinary straitjackets. We need to increase our repertoire of therapies, and we need to individualize care through a package of diverse options for our patients. Thank you.
Thank you. Thank you so much, Dr. K. Okay, thank you. I think that was a really vast topic with a lot of points. And what I'd like to just open the floor for a few minutes if there are any points you'd like to make or clarifications you'd like from Dr. K.S. One issue, I mean, I don't know if it's come up before, so I just joined the meeting, but the book of Dr. Paul Brand, The Gift of Pain, has been quite a challenge to read and very empowering in a way in how to deal with these. And one interesting point he makes is about the three-dimensional view of pain, that there's first a sensory, the receptors that actually give the signal. Then there's the gating process that happens at the spinal lower brain level. And the third is the response that we actually have in our minds. And a lot of it has been focused over time only on the signaling and the gating and trying to block it medically. But how we actually respond as an individual, especially when it comes to chronic pain, when we have control on how we think about the pain that we are perceiving, I think that's a huge area that needs to work on. I just touched upon a topic of suffering. I think that's another huge area about the perception and how we deal and what even the spiritual aspects of suffering in the religious context. Anyone would like to raise a point or contribute, please do so. Otherwise, thank you very much, everyone. Thank you, Dr. Jacob, and we can move on to the next topic. Thank you.